Hi everyone, moving on to our PALS algorithm. In this video we're going to take a look at the tachycardia with a pulse and adequate perfusion algorithm. Now, when we're thinking about kids, we're always thinking respiratory. So step one, check that airway. Make sure the child has an airway, they can maintain their own airway, and they're not in any respiratory distress. No grunting, no wheezing, no retractions. His breathing, his respiratory effort is fine. You're also going to get a baseline set of vitals, and yeah, you have to take a blood pressure. Get your OPQRST and your sample history. You're going to get this from mom. Next in the algorithm, we're going to take a look at the ECG, the electrocardiogram. And a 4-lead right now would be fine. You can get a 12-lead later on, of course, but a 4-lead is fine. And what we're looking for specifically is the width of the QRS. And they determined, they being the American Heart Association and the Academy of Pediatrics, that a wide QRS for a child or an infant is greater than 0.09 seconds. So let's take a look at the ECG paper that we're using to measure this. Now remember, the smallest box on ECG paper is 0.04 seconds. 2 boxes, 0.08 seconds, and 3 is 0.12 seconds. Okay, we're looking for 0.09. Great. So how do we measure this? Well, each small box is 0.04 seconds. So if we took that small box and we cut it into 4 pieces, each of those pieces would be 0.01. Therefore, we're looking for 2 small boxes plus a quarter of the next small box. That's 0.09. So if it's greater than 2.5 boxes, it's considered a wide complex QRS for a child or an infant, but that's how you're going to look at it. Now, these tachycardias come in basically 4 flavors. One, your sinus tachycardia, and you're going to see this all day in the ER. The most common, you'll see it all the time. The next would be an SVT, a supraventricular tachycardia. Not as common as sinus tach by any means, but you do see them quite frequently actually, and we're going to talk later on about a patient I had this week. The next category would be a supraventricular tachycardia with an aberrant ventricular conduction. And what this is a rhythm that's actually originating supraventricular, but then when it gets to the ventricle, it takes an aberrant conduction. It goes off the normal pathway and it creates a wider QRS. Now we're kind of moving into unicorn land a little bit. You don't see these very often. The last category is ventricular tachycardia, and this I would call evil unicorn land. Nobody wants to be in ventricular tachycardia with a kid. Nobody wants to be in evil unicorn land.
Oh no, this is it!
But thankfully they're very rare. They don't happen very often, but we'll talk about what to do when it does happen. So let's start with the most common, sinus tachycardia. Now, sinus tachycardia comes with a story. Yeah, that's right. Sinus tachycardia is compensatory to something else. So there's a story with this kid. The kid was sick for days. He wasn't taking in any oral fluids, vomiting, diarrhea. There's a story that matches and accounts for this sinus tachycardia. So the treatment fixed that underlying cause. If the child's volume depleted, we're going to give him volume. Generally, 20 cc's per kilogram of a crystalloid fluid is the first volume replacement bolus for a child or an infant. And then treat the underlying reason. If he's sick, he might need antibiotics, he needs further care, but we're treating the underlying cause. Now, looking at the ECG, this is where we're going to determine it's a sinus tach. 1, it's sinus in origin, so the EKG will have a P wave. There will definitely be a P wave present in this tachycardia. The QRS, of course, is narrow. The R to R intervals can be a little bit off. It can be slightly irregular. Although when the rate's really, really fast, it's hard to tell, but it may be slightly irregular. Next, look at the rate. In a child, the rate should be or generally is less than 180. In an infant, the rate is usually generally less than 220. Next, supraventricular tachycardia, or an SVT. Now with these kids, they don't come with a story. There's no story to it. It just popped up all of a sudden. that day. It just popped up. There's no real story. Nobody knows what's up. All of a sudden, the kid's acting a little fussy. Oftentimes, what I'll see in infants is they don't want to eat. That's what happens. They just don't want to eat. Mom brings it in because the kid is acting funny, but no real story to it. Next, for an SVT, we look at the ECG strip. 1, there's no P wave. No discernible P wave in this rhythm. The R to R's tend to be very regular. And in SVT, they're just marching out, off they go. But they're regular R to R intervals. The rate, generally greater than 220 in an infant or 180 in a child. So remember those cutoffs for tachycardia. An adult, 150, a child, 180, an infant, 220. Those are your upper limits for tachycardia for those 3 categories. But today we're just talking about kids and infants. So look at the rate. Next, let's talk about the treatment strategy for a supraventricular tachycardia for a child or an infant. We can start with vagal maneuvers, just like an adult. Now, in an infant, you could try taking maybe a plastic glove or a plastic bag, put some ice and a little bit of water in there, and cover them quickly over the eyes. Don't cover their airway, obviously, but cover their eyes with this cold ice water, and that may stimulate a vagus response and slow the heart rate down. If not, we're going to use adenosine, just like an adult. The dose for adenosine in a child or an infant, 0.1 milligrams per kilogram. And that's one of the 0.1 drugs. There's a lot of drugs in pediatric land that are 0.1 milligrams per kilogram dosing, and adenosine is one of them. Now, if it works and the child goes back into it, you can repeat the dose, double it, 0.2 milligrams per kilogram. After that, and regardless, you're going to want to get an expert consult on this kid. Unless you have a pediatric intensivist and a PICU at your hospital, you're going to want to seek outside consult for this SVT in the kid. Now, obviously, when you're calculating your doses for a kid, never exceed the adult dose of adenosine in a pediatric patient. Okay, so we just talked about our 2 narrow complex tachycardias, sinus tach and SVT. Now we move over to our wide complex tachycardias for a kid. The first one is a supraventricular tachycardia with an aberrant ventricular conduction. And the treatment, believe it or not, is the same for an SVT. So we can start with vagal maneuvers, or we can also try adenosine. Now, we're going to get an expert consult for this kid. You're going to get a 12-lead EKG, and you want to get an expert involved with this child quickly. Next, let's take a look at the last and probably most infrequent tachycardia in a child or an infant, and that's ventricular tachycardia. You're not going to see this very often. Step 1 to treating a ventricular tachycardia in a child or an infant, get an expert involved. We don't see these all the time. We're in evil unicorn land. Get an expert involved quickly. Get a 12-lead EKG. And we can treat this arrhythmia with amiodarone, the same antiarrhythmic we would use for an adult. The dosing, 5 milligrams per kilogram over 20 to 60 minutes. Hopefully, while we're transferring this kid out. Now, my paramedic program takes place at the hospital. So I'm teaching in the hospital, which is great because I can bop up to the ER and discuss patients with my students right there. So yesterday I get wind of a 2-month-old coming in with an SVT. He'd come into the ER. And I went up there and I wanted to learn what was the presentation, what was this kid doing, presenting, that mom said, hey, this is where we got to take this kid in. Because that's the information I want to share with you guys. So I go up there and find out nothing. Absolutely nothing. This 2-month-old was at his regular doctor visit for a checkup. That was it. They just threw the kid on the rack, make sure he's growing, got all his fingers and toes. And this very good doctor, before the patient left the doctor's office, he took one last listen to the lung sounds and detected a heart rate of 300. This child was in an SVT. Step 2, we're going from the doctor's office in the ambulance to the ER. We get here in the ER. They still called our pediatric hospital very quickly, got them on the phone. He got his 0.1 milligram per kilogram of adenosine, converted, then went back into it. They talked to the baby doctor, and he said, give him the 0.2. They did that. The child converted into a regular rhythm, and he was fine. And through the whole episode, the child was asymptomatic. And I've observed that infants respond very well to adenosine. So he converted. They also ordered a bolus of 20 cc's per kilogram of crystalloid. And then step 3, we're going to put the kid in another ambulance and take him off to baby hospital. But that happened yesterday. But again, in this case, the child was entirely asymptomatic without any presentation that they were in an SVT. Caught it by the luck of the draw. I'm Mark. Thanks for watching. See you in the next video. This will be a pediatric tachycardia with a pulse and adequate perfusion algorithm.